All righty. So I'm going to share my welcome. There we go. All right. All right, welcome everyone to the 2023 PI conference. We will get started in just a moment. My name is Dr. Catherine Lontock, and I am the Director of Science and Policy Communications here at IDF, and I'm going to be your host for this afternoon's Q&A session. And today you will get to ask your very own questions pertaining to immunology and PI. So there is no presentation for this, just a Q&A. Before we get started, a few housekeeping rules. First of all, everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of your physician or another qualified health provider with questions concerning a medical condition. Second, the focus of this session is on the adult population, so please do not ask pediatric-specific questions. Please also avoid questions specific to a brand of medication or that name a specific provider. And please avoid sharing stories or seeking advice that is highly specific to your unique health journey. Certainly, we want to answer your questions, but we would like the questions to be relevant to other people in the audience as well. So without further ado, I am excited to introduce you to our expert of the hour, Dr. Malik. So Dr. Harry Malik is Chief of the Genetic Immunology Section and Deputy Chief of the Laboratory of Clinical Immunology and Microbiology at the National Institute of Allergy and Infectious Diseases at NIH in Bethesda, Maryland. He obtained his medical degree from Yale University and did postgraduate clinical and research training at the University of Pennsylvania, the NIH, and Yale University. He stayed on at Yale as an assistant and then an associate professor of medicine before returning to NIH as a senior investigator. Dr. Malik's research team at NIH is focused on both preclinical development and conducting clinical trials of allogeneic stem cell transplant and gene therapy for inherited immune disorders. His laboratory has developed new approaches to gene therapy and gene editing, including enhanced methods of lentivector transduction, improvements in the mobilization and collection of hematopoietic stem cells, optimization of conditioning for transplant and gene therapy, and the prevention and treatment of transplant-related graft versus host disease. He has pioneered improved methods for generating induced pluripotent stem cells from very small volumes of peripheral blood and the use of these stem cells to model gene editing for inherited immune disorders. Dr. Malik has authored over 300 research manuscripts, as well as editorials and reviews. He serves currently as the chair of the NIH Institutional Biosafety Committee, which reviews all gene therapy clinical protocols conducted at the NIH Clinical Center. He's a past president of the American Society of Gene and Cell Therapy and an elected member of the American Society for Clinical Investigation and of the American Association of Physicians. He also serves without compensation in an advisory capacity to biotech, gene therapy, and pharmaceutical companies. Thank you so much for joining us, Dr. Mallett. All right, so let's see. We already have some questions. Okay. I have CVID with allergy-like symptoms, but normal low IgE and IgE allergy tests are always negative, although skin tests are positive. What could this be? Tryptase is normal, by the way.
So please understand that it's hard for me to take a question in which I'm trying to work out a diagnosis for you in real time without seeing all your medical information and so on. CVID is a diagnosis usually of adults. The same kinds of problems and symptoms in children are more likely to be due to a gene defect that's easy to identify. CVID has been evolving over the last number of years, in which many patients with CVID, after undergoing extensive testing of their genome using usually whole exome sequencing with analysis of that, I would say, almost half of such patients now have been diagnosed with a specific disease, which then often makes the diagnosis specific to a specific gene, and therefore people can then come up with more specific answers to your question. So rather than trying to answer your question directly and give you personally a diagnosis of some kind or a recommendation for treatment, I would instead say that if your physicians have not yet worked to see if they can find a genetic diagnosis, that would be one of the early things that we're now recommending that all patients undergo, as they might find a very specific gene defect that would then more specifically guide their treatment for you. I'm sorry, I can't sort of take what you've given me and come up with a medical diagnosis or a treatment plan. But the next best thing is to give you some more general advice that I think is true of all CVID patients. That is that the current effort is to try to see whether all such patients might have a specific genetic diagnosis.
All right. I actually have a related question here in the chat. Would there be any reason to have genetic testing? I have CVID and my doctor is not in favor of it because I'm told it won't change my treatment.
So to be fair to your doctor, most of the time when a specific gene is diagnosed as the cause, the general treatment is still the same. But often, not only does it give a patient and family a sense of understanding, but if you know what the genetic diagnosis is, then you can also provide genetic counseling, knowing how its inheritance might affect relatives or offspring. And to be absolutely clear, occasionally the specific diagnosis does in fact influence the specific treatment that you would receive. So I think I'm reflecting most of the experts in the field now that if a generic kind of testing, part of the problem is these days it's not very cost effective to make guesses and keep looking for different genes. But if your doctor can connect with one of the major centers that is now offering genetic testing of a broad kind, like whole exome sequencing and analysis, it's worth trying to get that done. if your doctor doesn't do it or can't find a place to do it, likely the Immune Deficiency Foundation can make some recommendations, since there are some programs now connected with the IDF that may help with that. But this is all very new, and I'm not criticizing your doctor for not looking, because it is true that in most cases, even when you find a genetic diagnosis, it may not change your care.
All right, thank you so much for that answer. Lots of questions coming in. I'm just going to go in order, I think, unless there's a connection between two of them. Is it common to have chronic diarrhea with CVID? What can be done?
So there is a subset of patients with CVID who have inflammatory bowel disease. And there's some very interesting work that's been performed by a number of centers, but I just happen to know because the group is here at the NIH. Ivan Fuss and Warren Strober here at the NIH program have actually made quite a lot of effort to find out what groups of cytokines may be abnormal in that subset of patients with CVID who have a significant inflammatory bowel disease. And they've found some very specific and cytokines that may be affected in subsets of these patients that have helped to guide therapy. Again, I'm not suggesting a specific therapy, but it's worth pulling up some of those papers by Ivan Fuss and Warren Strober as a start, and you'll see that there's quite a bit of work done to understand the basis of inflammatory bowel disease in CVID. And it's different from Crohn's, it's different from ulcerative colitis. It's its own type of inflammatory bowel disease. Again, not affecting all CVID patients, but those who do have inflammatory bowel disease. It's quite specific to this disorder.
All right. Here's one about COVID vaccination. It's been over 6 months since I had my second booster. Do I need to get a third booster now, or do I wait until the fall? So many people are saying that the vaccines are not safe. Please let me know your opinion on the boosters.
So in my personal opinion, the COVID vaccines are perhaps one of the safest set of vaccines that's ever been produced. And there's a huge amount of experience. Now, the question of when to get your next booster is controversial, let us say. I think that they're going to be coming up, we're getting so close to the fall that it wouldn't be wrong to wait until they have the new version of this for the fall. The general recommendation, though, is that if you have an immune deficiency, but you're likely to respond at least to some level to vaccination, that it's worth getting your vaccination after 5 or 6 months to get another booster. But again, you've sort of presented the question in a way that I think, yes, you should get your booster. Yes, it's safe, but I might wait for the fall version of this.
And I will say, just from a policy standpoint, that the FDA just recommended how manufacturers should formulate their boosters for the fall. So those are, I think all of the manufacturers are planning to target XBB 1.5, which is a Omicron subvariant. And it's the most.
That's the specifics. I agree.
Right.
Yep, thank you.
Right. Okay, also related to vaccines. Should we wait a week before or after our infusions to get any shots or vaccines?
So I'm very upfront when I actually don't know an answer to a question. I tend to think that vaccinations should be separated a little bit in time from getting your IVIG, But if you're getting sort of weekly Hizentra or something like that, then I would not I wouldn't worry about when you got your IVIG or your immunoglobulin supplements.
All right. we've
Bottom
got a-
line is, I don't really know the answer to the question. I would, if you're getting intravenous gamma globulin, you're probably getting it every 3 to 4 or 5 weeks, and so I'd sort of separate your immunizations out a little bit from that. But this is just a comment. I freely admit I don't know that there's a real answer to that. I don't think it matters.
All right. Going back to genetic testing, should all CVID patients be tested? If you were initially tested a couple of years ago, say 2021, and the results were negative, when should you get tested again? How often after that?
So that's a question that I have only an opinion. There's not a clear recommendation. In the past, what would happen would be that people would test for specific genetic defects. But what we're moving into is an unbiased approach in which people have whole exome sequencing that won't find everything. And there are new genes that come up. But if you've ever had whole exome sequencing, then the place that's done it has that whole sequence. And what changes over time is not the sequencing, but the new genes are discovered that they may interrogate your data. So it depends on what you had done. If you had a specific gene looked at or set of genes looked at, I wouldn't repeat that. Nor these days would I spend the money on searching for yet this gene and that gene. I would. What's happening is the problem with whole exome sequencing is that it's still considered experimental, and so it's done at centers that do this. You can't just go out into the community and have it ordered by your doctor yet. But the costs are coming down, and the ability to do that is changing, and I may even be behind the curve on that. But that's going to be the future, is genetic sequencing that's getting cheaper and cheaper, and the analysis is getting better and better, so that we don't have to make guesses anymore. We instead just sequence the whole thing and do a high throughput analysis. And then what you do is you reanalyze every few years, not necessarily have to redo the whole test.
All right. Again, on genetic testing, if no genetic variant has been found, is it still possible for children to present with CVID?
Definitionally, there are people who have defined CVID as an adult disease and not a disease of children. I think that's probably something that's going by the wayside now, as we're realizing that CVID is not a is more a diagnosis of you have an immune deficiency and we don't know the genetic cause. Almost certainly all CVID has some genetic reasons why it occurs. It may or may not be triggered by environmental factors, but it's almost certainly somehow related to your genome in some way. And over time, we're going to get better and better at defining what's still the majority of CVID patients, excuse me, for whom there's not yet a genetic diagnosis findable. The reason I bring this up is it depends on the genetics, whether it's a kind of CVID that would manifest earlier in childhood versus the kind of CVID that doesn't manifest until adulthood.
All right. Sort of changing gears a little bit. Do autoinflammatory diseases fall under PI? And what type of doctor typically diagnoses and treats autoinflammatory diseases?
So more and more we realize that immune disorders encompass a broad array of diseases, and very few of them are purely just immune deficiency or purely just autoinflammatory diseases. Instead, there's a whole spectrum with diseases that mostly manifest as autoinflammation, diseases that mostly manifest as immune deficiencies, but because even for a specific defined immune deficiency, there's often a broad range within that of patients and the kinds of mutations and so on, whether they are more on the inflammatory disease side or the immune deficiency side. The reason I emphasize that is that the entire immune deficiency community has come to embrace these autoinflammatory diseases as part of their what they need to have their expertise in, as well as the more classic immune deficiency disorders. In the past, it was mostly rheumatologists who would see the patients who manifested primarily as these what are almost pure inflammatory disorders or autoimmune inflammatory disorders. And so what I would say is you could see your immunologist, you could see your rheumatologist, but often a partnership between, let's say, a group that has both an immunologist and a rheumatologist on board would work best to diagnose and manage your disorder.
All right. I have CVID and chronic pain, muscle and joint pain, fatigue, exercise intolerance, etc. What can be done to try to find out why this is happening and what can be done about it?
So again, I unfortunately in this sort of setting, I can't go through and diagnose what should be done for you. What I can do is say that what you're describing sounds as if you've got significant autoinflammatory component to your CVID, and there are such a growing array of treatments that go way beyond the old, give people steroids. That I think if again, I would give the advice that seeing your rheumatologist, or even better yet, a group that has both a rheumatologist and an immunologist, or let's say a rheumatologist who ordinarily works together with an immunologist, would give you the best care to try to come up with a treatment plan, sort of going through a diagnostic array of things to see what is the cause of your inflammation. In other words, rather than just looking, do you have inflammation, people can also see what groups of immune hormones are being hyperactive in your case, and that may guide people on the specific treatments that they might give you. That's about as specific as I can get, I think.
All right. Well, you ended up answering a couple other questions as well. So our next one is about IgG deficiency. I am newly diagnosed with IgG deficiency. I'm not yet on Ig replacement and will see a second immunologist soon. I have symptoms of autoimmunity, but have tested negative for autoantibodies. Is it possible to have a false negative?
So, that's a 2 or 3 for question. So let me see if I can answer the one you you asked first. Autoantibodies are the understanding of autoimmune antibodies has become much more complex than it used to be. In years past, people had a series of specific autoantibodies that they would look at that were kind of generalized tests. But these days, you know, there's more ways of looking at this that include analysis, more specific analyses of your B cells and so on. The question, however, is whether doing an extensive search to find out, do you have one of these rare autoantibodies, may or may not lead to some different way of treating you. So, you know, I would, there's always, one always needs to have a balance between how much diagnostic work you do, how much it costs you, particularly there's always going to be copays and so on, and whether you're likely to find something that's going to affect your therapy. Maybe if you could repeat the question, because there was a front part of that I also should be answering.
Yes, the front part was about being newly diagnosed with IgG deficiency and seeing a second immunologist, have not started replacement therapy yet.
So often at immunology meetings or immune deficiency meetings, there'll be debates about and even the IDF has tried to pull together groups to try to come up with specifics. You know, who should get supplemental IgG? Should it be based entirely on a particular level? That is, if your IgG is below X amount, do you get it? Do you only treat people who have low amounts, or do you also look and see whether people are responding to immunizations? And if they don't respond to immunizations, even if they have not terribly low IgG, but they don't respond to immunizations, they may need and benefit from IgG. So it's a complex question. The answer is, if it's low, probably you would benefit from IgG. If you had recurrent infections of certain kinds, it may help that. Will it help your auto-inflammatory problems? That's hard to tell. It may or may not.
All right. Have there been any gene defects identified for the diagnosis of specific antibody deficiency?
Yes, there are a number. I can't. I'd have to do my own homework to sort of draw a list. But as you may know, there's also severe antibody deficiencies such as X-linked A-gamma globulinemia. But it sounds like you don't have that. But there are other specific diseases that result in low immunoglobulins, and it's another place where, based on the studies that are done by your doctors, they may come up with some specific things they may want to send away for some genetic testing. But like the CVID issue, I think eventually we're going to get into an era where whole exome sequencing is available, and many of patients such as you will eventually get that done, and somebody might or might not come up with an answer.
All right. Is it common for those with CVID or other PIs to have many true allergic reactions to medication, such as anaphylactic reactions to most classes of antibiotics?
I'll give a really, really interesting story. We had a patient many years ago with X-linked A-gamma globulinemia, meaning it's a disease affecting boys and men, and they can't make any immunoglobulin, none whatsoever. And you'd think, how can you have an allergy in that kind of setting? But this unfortunate person kept having hives every time he got his needed supplemental IVIG. And eventually we sorted out that that in fact it was a T cell mediated reaction to the IgG. Really, really rare thing. I give this as a story, like a little vignette that says that surprisingly there are many ways to get allergic types of reactions, and even people with severe, diagnosed with known severe immune deficiencies can sometimes figure out a way to have reactions that are immune mediated to needed supplements, to antibiotics, to foods, to whatever. So the answer is yes, you could have medicine or food related allergies even with an immune deficiency.
All right. I have CVID diagnosed as an adult and have 2 children with CVID diagnosed as young children. I have several autoimmune conditions, including severe rheumatoid arthritis. What are the chances that they will develop these autoimmune conditions as they age, meaning the children?
I don't have a crystal ball. If I could predict the future, I'd be a rich man. I'd know what stocks to buy. What I can tell you is that whatever is causing your CVID, if they also have CVID and you have a set of problems, it's not a foregone conclusion. I can't predict they will get your problems as well, but I can say that it's possible they will. But genetics isn't destiny. Genetics is a guide, and environmental things interact with your genetics in ways that end up with the kind of set of problems that you have from your genetic disorder. I would say, though, that if your children also have CVID and it appeared in childhood, then the likelihood that this could be a genetic disorder that could be diagnosed through whole exome sequencing becomes higher than it would be with an isolated patient with CVID who has that kind of testing. So I would discuss this with your doctor.
All right. Speaking of doctors, do you have any tips for breaking in a new doctor that has not heard of your ultra rare diagnosis?
So I have generalized advice, and that is that the vast majority of physicians who aren't experts in the field, who are general practitioners in a sense, or internists, are enthusiastic and willing to partner with, or at least listen to, an expert in that disease, and use and take advice from that expert. A physician who says, no, I can handle this. No, I've not taken care of your kind of disease before, but I can read the books and I can do it just fine, and I don't need any advice from anybody else. That's probably not your best physician. That's all that's general advice. In other words, as my patients here at NIH, they come from all over the country. And so I can't be their primary doctor all the time. I have to rely on their local care. And all that I ask is that local care people be receptive to, not always listen to what I have to say, but at least be receptive to my giving a call or whatever, and be receptive to even the advice. Often patients, particularly adult patients who've lived with a disease for a long time, know an awful lot about their disease. And a physician who is resistant to learning from what his patient knows, or resistant to interacting with your former physician who knew your disease well, is probably not your best next choice.
All right. I have CVID and am on immunoglobulin, but still getting frequent infections. What should be done or looked into?
Again, it depends on what the specific infections are and so on. It could be that interacting with an infectious disease expert whom your immunologist or rheumatologist is comfortable interacting with, they might be able to come up with either a prophylactic antibiotic regimen. Again, I can't say you need prophylactic antibiotics. I could just say that is one of the potential options. The other option, which I sometimes do, is if a patient is not having infections literally all the time, but instead goes for reasonably long periods, but then has a very similar infection, and we kind of know what the organism is that they're getting, I may give them the antibiotics they need for that. So it's sitting there in the fridge, and when they get that symptoms again, they'll start that antibiotic, but call their physician as well, so that there's not a delay in getting an infection treated. It's just a general kind of thing that I use with my patients that can, because usually what happens is that next infection only becomes apparent at 10 o'clock on a Saturday night. And gee, wouldn't it be nice to have some antibiotics you can start, and then call your doctor the next morning or on Monday, and he or she can say, no, you shouldn't have taken it, but that's okay. We'll go forward from here. Or great, that's good that you started, because maybe we nipped it in the bud early. But that's a general kind of advice. I would need to know more about your specific infections, what they are, what organ systems they are affecting. Is it sinusitis or bronchitis or pneumonias or urinary tract infections or whatever? So.
All right. What new innovations are possible in the future for treating CVID?
Again, CVID is a general diagnosis. It doesn't tell you what the genetics are. There's been great controversy over the years about whether CVID patients should be considered for transplant. And it used to be that no one would consider that. But with really severe CVID, even if a genetic diagnosis isn't found, there are some centers and some physicians who are beginning to consider transplant for such patients. I'm not recommending transplant to you because I don't know the degree of your disease. Fortunately, the vast majority of CVID patients are, it's a chronic problem, but they're in the category of mostly okay, mostly functioning, rather than mostly sick. I certainly wouldn't transplant those patients or recommend that. The problem with my recommending anything else is it kind of depends on your symptoms and so on. As you heard, the person who asked about severe inflammatory problems and fatigue and muscle aches with CVID, I recommended some diagnostic work that might come up with a set of immune hormones that are high that would then lead to using one or another of the non-steroidal specific anti-inflammatories that are out there.
Somewhat related, can you speak to any exciting research or newer treatments to modulate or treat specific genetic mutations related to primary immunodeficiencies?
So as you heard from the short introduction, our laboratory has been quite focused on what I call, hopefully curative, but certainly beneficial cell therapies that include either allogeneic transplant, but we've also been highly focused on some of the newer ways of developing gene therapy. We're still in the very early days of gene therapy, but for some diseases, gene therapy has proved to be pretty effective for infants, for example, with adenosine deaminase deficient SCID. The lentivector gene therapy trials were spectacularly beneficial to these infants and curative. Now, since this is a session in which we're talking mostly about patients with adults with problems, and I'm not focused on the pediatric part of it, though though I must admit, it's hard to separate the pediatrics from the adults because, many of these so-called pediatric immune deficiencies have been handled so well that many of these people are now young and even middle-aged adults. And so the general comments I'm going to make apply to everybody. There are some spectacularly interesting developments in the field of gene editing. And I don't want to make this an entire talk about gene editing, but the advent of CRISPR in particular has opened up the avenue to some extraordinarily interesting ways of correcting hematopoietic stem cells in particular, by literally repairing the gene that's abnormal. Lentivectors tend to work by introducing a missing gene. So, for example, if you're missing protein X and that's causing your immune deficiency, and it's missing from your immune cells, one can deliver a lentivector that goes into the cells and lands in the genome and will produce that missing protein. And as I say, some of these lentivector developments have been spectacularly successful. The problem is trying to bring down the cost and complexity of gene therapy. And again, I don't want to make this a whole lecture about that, but the workers in the field are very, very sensitive to the fact that these are complex ways of correcting cells that currently incur very high expense. And that's been one of the problems. The other problem has been that the vast majority of immune disorders, and so I'm talking not only about the immune deficiencies, but across the spectrum of autoimmune disorders, are rare diseases. That is, only a couple of hundred or a couple of thousand in the country, but together, there's now more than 400, almost close to 500 of those diseases. And what's happening is that most of the commercial enterprises are focusing primarily on the ones that are more common. But if you take the whole group of immune disorders as a whole, and you add them all up, the whole group includes more people, each with some rare disorder. And I think we're going to get better and better at figuring out how to deliver gene therapies for these rare disorders in a way that's cost effective, but basically the field has not forgotten about you. We're going to work on this. This is of great concern and interest. In fact, we had a meeting recently, an international meeting, just in early June, in which we discussed the problem of how do we develop and deliver gene therapies for all these very rare immune disorders. So the field understands that this is more than working out the science. We have to work out the whole delivery system and the costs and access.
All right, so we
Sorry
probably
to go on and on. You touched on my particular special interest, so I thought I'd take a little extra time on that.
Sure. We probably have time for maybe 2 more questions. What causes lung nodules with CVID? How are they treated? And can they become malignant?
I need to beg off a little bit because I'm lung nodules can occur in CVID, and they can be infectious, or they can be sort of immune granulomatous nodules, or they can be malignant. In other words, it depends on what kind of nodule it is. If it's an infection, it's unlikely to become malignant. If it's inflammatory, it won't necessarily become malignant, but that's not impossible. I think what's more important is to say, if you've got a nodule in your lung Somebody needs to do a biopsy to know exactly what it is and make a diagnosis. That needs to be done. Beyond that, it's hard for me to provide more answers to your question.
All right. Let's see. Do all people with DOCK11 gene mutations need Ig replacement therapy for lifelong?
So DOCK11 is a fairly newly diagnosed disorder, and I must admit that a couple of my colleagues here at NIH have been deeply involved in their in diagnosis and care of this newly defined disorder. But I'm a little anxious about doing my homework before I gave you an answer to a question. What I will say is that some of those patients I know do need supplemental IgG, but you're going to have to depend on your immunologist and rheumatologist to determine what's best for you.
All right. Is it common for CVID patients to have an inability to run a fever?
So that's I would turn the question around, and I would say, I'm not aware of any CVID patients who will not run a fever if they're given enough of a stimulus. In other words, if they have a big major infection, they will eventually run a fever. What I will say is that not all problems that occur, and not even all infections, will cause someone to have a significant fever. What triggers fever are a very specific set of signals, and if it's autoinflammatory, you may not have an autoinflammatory situation that activates those immune hormones that cause fevers. It isn't that you can't have a fever. However, I will tell you that they're not CVID, but there are immune disorders, very specific ones, that have trouble generating fevers. But that doesn't quite, in other words, if what you've been diagnosed with is CVID, and it's sort of classic CVID, I'm not aware that there's a subset who can't have fevers at all.
All right. So I think we're going to wrap up with this next question, and I apologize if we haven't gotten to your question. I would encourage you to submit any unanswered questions to Ask IDF, and we will try to get those answered. I did put in the URL in the chat there.
Yeah, and if they come from this session, I'm happy to field those and make it and give answers. So we're not done here. This is just, we have a set of time and have to finish.
Yes. Yes, if you do submit your question to Ask IDF, please note that you are in the Ask an Expert session with Harry Malik, and we will get those over to him. I do think we can squeeze in one more question. Will newborn screening for non-T-cell disorders be possible in the future? Is research currently being done, and what are the roadblocks?
What I will tell you is that there's great interest in coming up with other methods that may be applicable to newborn screening. And I believe that we're not, just as newborn screening for SCID was not first, it won't be the last. You can quote me, but make sure you note that I may be wrong. But eventually, when whole exome sequencing and analysis becomes cheap enough and widely available, and that could be 5 years from now, 10 years from now, could take 20 years, I don't know. But I believe that we're going to be in a place where we will be able to do broad genetic screening on all newborns whose parents wish that to be done. But as for specific other subsets of immune deficiencies, I'm aware of people working on other types of newborn screenings. But developing an assay is only the first step. Many of you who know about the newborn screening for SCID realize that it took a state by state, almost 10 years of activity to get all of the states in the United States. And now there's many other countries, but it's still not worldwide yet. And so there's a cost and political aspect to this, and not just a scientific. I can address the scientific and say, absolutely, there are people working on other potential newborn screens, but they'll have to pass muster with respect to applicability in the general newborn screening program and acceptance and so on.
All right. Well, our time here has come to a close. I want to thank you so much, Dr. Malik, for answering all of those questions. And I have a feeling we'll have a stack of them from Ask IDF as well. So thank you in advance for taking time out of your day to answer.
Yeah, I really enjoyed this. And I try to stay within the bounds of what I think I know, and where I'm making a guess, I make it clear to people that it's an opinion, not the set record. And I'll do the same with other questions I may answer in the future through any that are put forward. Thank you.
All right, it's been an honor to have you join us today. I want to remind everyone that this is just one of 39 sessions being provided through our 2023 PI conference, and we hope you continue tuning in today as we explore other critical topics to the PI community. I also want to mention that if there were any sessions that you missed yesterday, the recordings for all of those are available. So you just need to go into the session in Cvent and you should be able to play those videos. Thank you so much again, Dr. Malik, and have a great day.
And thank you for the opportunity. This was a lot of fun. Thanks.
Thank you.